Hello, Westport. Good evening. Thanks for ignoring this beautiful weather outside and coming inside. I think this is a very, very important topic. I'm going to get off the stage immediately, turn it over to Bob Altbaum, Westport's favorite internist, though he's retired. But not really, because we all love him and ask him questions. Bob, I have this little, Bob will introduce our two fabulous specialists in a second, but thanks for coming. There's Bob.
That was an efficient introduction. Anyway, thank you for coming tonight, again, because it's a beautiful night, on a very important topic, which I think is the most frightening topic for most women and hopefully to the men that love them, which is breast cancer. Tonight, I will be introducing the subject, and we have two wonderful speakers, Dr. Jean Capassi, who's the director of the Smilo Breast Cancer at Norwalk Hospital, and Lisa Fong, a medical oncologist who specializes in breast cancer. So we're going to get started. And basically, why do we even care about breast cancer? It gets a lot of press. It's because it's an extraordinarily common disease. The numbers are really daunting. If you look over here, I'm going to go between pointer. If you look over here, 30% of all cancers in women are breast cancer. That's 1 out of every 3 breast cancers. 1 out of every 3 cancers in women is breast cancer. An astonishing number. The other thing that's really astonishing is if you break that down or you drill down to the individual woman, that means 1 out of every 8 women, that's 13% of all women in their lifetime, are going to experience and have breast cancer. An incredibly daunting number. I mean, if you look at the number of women here, it's a sizable amount of women that are going to experience that. The average age is 42, but it can occur, even 9% occur before the age of 45. So you have a large number, young women, older women. As we get older, the risk goes up significantly, but that is the statistics, and that's why we're talking about it today. Now, in terms of the actual numbers, you blow up those numbers, not from the individual, but to the population. There are 317,000 new invasive breast cancers a year. It's actually a little bit more. Those are ductal, the most common. 317,000. Then there are another 60,000 that have not spread yet. They're cancers, but they're localized, called ductal carcinomas in situ. And the most important statistic is that 42,000 women every year in the United States die of breast cancer. Remarkably, there are 4 million breast cancer survivors in the United States. So again, these numbers get really incredible. 400,000 women with breast cancer annually, 42,000 deaths, and 4 million women alive living with breast cancer. Again, frightening statistics, but honestly, there is room for hope and some very encouraging statistics. And this is another way of looking at encouraging statistics. If you look at, this is breast cancer, this column is from 1990, not that long ago. And this is from 2020. They may have even gotten better. But you can see that the number of breast cancers have actually gone up, but the number of deaths have declined from 31 per 100,000 women to 19. That's a 40% drop in breast cancer death in 30 years. That's incredible strides, probably largely due to better screening techniques, and also we understand the biology of breast cancer better, so we can treat it better. If you look at the 5-year survival, which it goes from 76% to 91%. Again, very encouraging statistics, despite those kind of frightening statistics I just presented. Interestingly, there is a discrepancy between Caucasian and African American, 92% versus 83%. That is partly due to the slightly different characteristics of the breast cancer and probably due to differences in access of care. So I'm going to review something a little briefly that I discussed a little bit more superficially in a prior lecture. What is cancer? And cancer simply is unregulated growth and multiplication of cells, unregulated, that keep growing till they form a tumor, and that tumor is then capable of invading the tissue that started and capable of spreading throughout the body through lymph channels and bloodstream. That's what cancer is, unregulated growth. It can start in any cell, but it occurs most commonly in women in the breast, And this is kind of a pictorial of the breast, but I found it a little complicated to get across what I wanted. So I found a cartoon, which I think is a little bit better. And basically, it shows you the functioning, working parts of the breast. Even though there's fat, and fat can become cancerous, and skin can become cancerous, but basically 99% of cancers come either from these lobules, which is the milk-producing cells of the breast, or from these ducts that carry the milk to the nipple for the baby. So lobular cancers are called lobular carcinomas, and there's lobular carcinoma that's invasive, and there's lobular carcinoma that's in situ, meaning it stays in its place, it hasn't spread yet. And then there are ductal carcinomas, and ductal carcinomas are the cells in the ducts that become cancerous, and again, they can be in situ, localized, or they can break through and break into the tissue of the breast, or spread through the lymph channels in the blood to virtually any organ in the body. And if you look at the numbers, this is really the breakdown of how breast cancer divides. 70 to 80% are invasive ductal carcinomas. Another 20% are ductal carcinomas in situ. This is the lion's share of what we're talking about tonight. It's the lion's share of what women have to deal with. But also, there's invasive lobular carcinoma, which makes up 10%. Lobular carcinoma in situ and all the others really make up a surprisingly small number of the cancers. So these three are what we really want to talk about and what we need to treat. They often present as abnormalities on mammograms. They can present many ways. Not all lumps are breast cancer. Lumps can be abscesses, which are boils. They can be benign. They can be simple cysts. But if you find a lump, obviously it's got to be addressed. It may be cancer. And as I said, 1 out of every 8 women will experience it in their lifetime. So how do we get to cancer? As I said, cancer is unregulated growth. And yet we know that we have to grow. We start as a fetus. We become an adult. That's a lot of multiplication of cells, a lot of growth. And yet it's all controlled, amazingly well controlled in the body. DNA, which is really basically the substance of life, has a way of making proteins that regulate growth and slow down growth. And it happens right now in our bodies, it's happening, and it's controlled, it's regulated. Cancer is when that regulation goes bad. When you look at DNA, very simply, I'm gonna just think of these, there are only 4 chemicals in DNA. They're called nucleotides, but think of them as letters in the alphabet. And when those letters line up, they spell words. In the case of DNA, these nucleotides line up, they spell proteins. But the letters of the genes basically spell words, and some of those proteins are involved in controlling growth. They make the cell grow. They make it multiply. And that's okay, that's their job. And they're called proto-oncogenes. There are other genes that control growth. They slow down the growth, and they're called tumor suppressor genes. So what happens normally is you have proto-oncogenes saying grow, you have tumor suppressor genes saying slow down or stop, and they're doing a dance together, and it's regulated, and everything is fine. What happens is that the DNA is constantly multiplying. Every time a new cell is made, DNA divides. Has to create another whole DNA of the entire cell. Lots of opportunities for mistakes. And those mistakes we call mutations. So when I said these letters spell words. So if you have the word cat, and there's a mistake, it's now spelling tack. Well, that's spelling a new protein, and that protein may be dysfunctional, may not work properly. So if you think of that proto-oncogene that controls growth, and that growth protein now is mutated, it's a mistake, it doesn't turn off. It's a little bit like a car with an accelerator that's stuck to the ground. It's supposed to turn off. It doesn't know to turn off. That car is going to crash into a cancer wall. That cancer will develop because the gene is multiplying, multiplying, multiplying. The other, or flip side of that, is that there are genes, tumor suppressor genes. They slow down growth. But what happens if that mutates? And now it's not doing its job. Now it's like a brake that's failing. The car's going, the brake's supposed to say slow down, tumor suppressor gene isn't working, you now have the car keeps going, crashes into the cancer wall. Now those mutations don't happen all at once, they can happen in small pieces, and they happen over time as we age, which is one of the major reasons. The greatest risk to a woman is aging. That is the greatest risk. Being a woman and being over 45 is your greatest risk for breast cancer, which we'll talk about. And this is just kind of that analogy of the accelerator, a little bit clearer. Here's your proto-oncogene, here's your tumor suppressor gene, that's your brake. If the proto-oncogene becomes an oncogene, there's too much gas, bang. If the brake is not working, it's deflated, the tumor suppressor gene, bang, you have a problem. The other thing that's important, using the car analogy, is that you need often a mechanic. If the brake is broken, get the mechanic to fix it. Well, there are genes that do that. They're called DNA repair genes. Remarkably, they know when a mutation has occurred and they can fix it. But what if they're the one that's mutated? Now you know these genes are mutating all the time and you can't fix them. Again, that's another way that cancer develops. The cell doesn't know to stop growing. This is just a list of some of the genes. I'm not going to go over that. The BRCA gene is the famous gene. Everybody knows that. And you can see if that happens, you have a 50 to 70% chance of developing breast cancer in your lifetime. It's no longer 13%. Fortunately, only 5 to 10% of cancers are due to these known gene mutations. Only 5 to 10%. The rest of them, basically, we don't understand them or know them, but we know that they're happening. Another thing very important is that most gene mutations are not inherited from your parents like a BRCA gene. Only 5, 10%. 90 to 95% of them occur during your life, either because you're aging and cells are dividing and one of the cells goes rogue. It may happen because of estrogen and progesterone, which can promote growth quickly, and that can cause mutations. So again, it's really important. People and women will often say, well, I don't have it in my family. I live a good life. That just doesn't work, unfortunately. The numbers don't belie that. The numbers show that 90 to 95% of women will have these acquired problems, not from their family. And so every woman has to basically be conscious of it. The only thing I wanted to mention in this slide, we'll talk about risk factors, because when you take these gene mutations, you can't really check women for mutations. We're not checking every person. It would break the bank and probably wouldn't find many. We only know a few. But what we do know is we can use risk factors. Risk factors are simply things that increase your risk of developing breast cancer. Now, only 25, 30% of women have real significant risk factors. Again, 70% of women, other than being a woman and being over 45, have no major risk factors for breast cancer, and yet they develop breast cancer. Part of the reason is that's a very large pool of women. But the other reason is you've got to be vigilant as a woman. But one thing, 1 out of 4, I was surprised at how low this number is. Only 1 out of 4 breast cancers are truly preventable by lifestyle, which makes me realize that 75% are risk factors we don't control. They're just risk factors that happen. A lot of women focus on, and should focus on, maybe avoiding alcohol, trying to stay away from hormone replacement therapy. That's good rules of thumb. But again, it is not avoiding the need to be screened and tested. So this is kind of a list. It's not meant to be daunting, but just to show you that most risk factors are not modifiable. Age and female gender, only 1% of breast cancers are in men. 99% are women. Being a woman is a big risk factor. Aging is a risk factor. Obviously, mutations, which can occur, most of them are acquired. Obviously, only 5 to 10% are inherited. Family history, there are things we don't understand about genetics. For instance, even if you do genetic testing on a woman or her family and you don't find a gene, if her sister, her mother, or her daughter have breast cancer, her risk of breast cancer goes up 2-fold. So even though we don't know exactly what it is, we do know there are other risks that occur just from being in the family. Personal history of breast cancer shows you have a predisposition. There is a difference in ethnicity. White women have a greater risk for breast cancer than black women, and yet black women have a greater risk of dying, again, probably because of different types of cancers and access to care. Dense breast is an important thing. It's actually an issue because of insurance as well, but a dense breast not only increases your risk of cancer because it suggests there's more breast tissue, there are more lobules and more ducts, but also the density of the breast makes it harder to read a screening test like a mammogram. You can miss breast cancers on mammograms if the breast is very dense. I don't want to go over all these except just to bring up estrogens very briefly. Estrogens by themselves are not a really truly dangerous thing to the breast, it seems. In postmenopausal women who don't have a uterus, when you're giving them hormone replacement therapy, you don't need to give them progesterone. And you can give them just estrogen. And those women don't have a significantly higher risk of breast cancer than women who never got it. But if you add progesterone, it goes up. And it seems to me that progesterone somehow amplifies the effect of estrogen, amplifies the effect of multiplication, and increases your risk. So these are all non-modifiable. If you have estrogen and progesterone, let's say you started menstrual periods very early. If you started very early, you're going to have more menstrual periods. That's more estrogen, more progesterone cycling, greater risk of mutations because you're duplicating more. If you have menopause very late in life, instead of 50, it's 58. That's 8 more years of getting estrogen, progesterone. And again, that can increase your risk. But you can't do much about these, so why do we care? Well, we care because if women have high risks, we can do better screening, or we can be more aggressive about screening. So even though we can't change these, we can definitely modify a woman's risk of dying of breast cancer. And these are, I kind of alluded to these briefly, but these are modifiable risk factors. The one that's very important is probably alcohol and HRT. HRT is important in a woman who gets both estrogen and progesterone. HRT is hormone replacement postmenopausal. Alcohol, which has for years been lauded as a good thing, has gotten under a lot of negative press. And with breast cancer, if you're a woman and you drink 1 drink a day, your risk of breast cancer goes up 7%. Now that's not 7% on top of 13%, that's 7% of 13. So it goes up about 1% absolutely. If you drink 2 or more, it goes up 20%. Well, that's now 20% of 13 is about 2 to 3%. To me, that's a large absolute risk. You're going from 13 to 16 or 17% risk of breast cancer in your lifetime. It's a very important modifiable risk. And when I said we kind of assess risk, these are just different, well, actually, let me just go over this. This really wants to emphasize that less than 25% of women have high-risk positive features. So women need to know that they need to be tested, even if they don't have it in their family, even if there's nothing they're doing wrong, even if they're very physically active, they need to be tested. But I like to think of risk factors in terms of personal characteristics, hormonal, personal breast history, and family history. It's just a practical way of thinking about risk factors as opposed to a long, long, long list. When I was preparing for this talk, I did find something I found interesting. Going in the internet is always, it's always an experience. And what's out there in terms of what people think is very high risk really is scary. And whether it's TikTok or YouTube or just things on the internet, breast implants have gotten a very bad press. Now there are 2 cancers that are linked to breast implants. One is a lymphoma, not a ductal cancer, not a lobular cancer, a lymphoma. And it's linked specifically to implants that are textured. It's about risk of 1 in 3,000. I don't think would change your life because of that as opposed to 1 in 8, but it is a risk. The other risk I didn't really know about, but there's a squamous cancer, which is 1 in 100,000. Again, these are not reasons to remove implants, but something to think about. If you're going to put in an implant, you might opt for a smooth implant. I'll leave that if Jean has a thought on that. But these are the other things. Diet, other than possibly fat, has not been shown to be linked. Alcohol, yes, but diet, no. Smoking, surprisingly, is probably the only cancer that smoking isn't heavily linked to, but it's not strongly linked to breast cancer. But these I found just remarkable. Bras, there's stuff on the internet that says bras cause breast cancer. There's no evidence for this. There's stuff on the internet that says antiperspirants cause breast cancer. Not true. Trauma causes bruises, it can cause lumps, does not cause breast cancer. So again, very, very important. There are very important risk factors. There are many things that are meaningless. And when you want to address a risk factor, some doctors will try to tabulate that, give it a score. These are different ways of giving a score. You don't really have to look at it, except they just include those personal factors, those breast history factors, those family history factors, and your hormone factors. And they can give you a number. Why do we even bother? Because if you have certain risks that are very high, a woman might be getting more frequent mammograms, or maybe contrast mammograms, or ultrasounds, or MRIs. Again, we leave that usually to the specialist. So in closing, I just want to make these simple points. If you remember nothing else, I think we all know breast cancer is very common. 1 in 3 cancers, 13% of all women. Only 25% of breast cancers are going to have lifestyle changes attributable. Why is that important? It's not that you shouldn't do it, but 75% can do everything right, you can still get breast cancer. Only 5 to 10% of them are due to inherited mutations. Again, the reason it's important is if it's not in your family, you are not protected sufficiently. Every woman is at risk, and you should all be screened. So thank you. I'm going to turn over the microphone to Jean Capassi. Jean is the director, as I mentioned, of the Smilo Breast Cancer Center at Norwalk Hospital.
Thank you, Bob. Hi, everyone. Thank you for coming. Thank you for that introduction. That was great. So I am a breast surgeon, and I'm going to talk mostly about the diagnosis of breast disease and then treating breast cancer. And my takeaways, I just want to mention it at first, and of course this was just stressed, that everyone is at risk. And so if you see something, it's very important to say something. Sometimes people feel something in the breast. They say, oh, go for a screening mammogram, and then if I don't, if it's fine, then I'm okay. Well, mammograms don't show everything, so make sure you bring it to the attention of your doctor, and if it's not going away, see a breast surgeon. And then when it comes to breast surgery, less is just as good as more. So I'll just review this briefly because we already heard about risk factors, and breast cancer is an important problem. The American Cancer Society expects there to be over 316,000 new cases this year. And I want to point out that our incidence in Connecticut is higher than the national average. We don't really know why, but consistently, our state ranks one of the highest in terms of numbers of breast cancer. So these were statistics for this year that the American Cancer Society put out, that on average in the US, there's 133.8 cases per 100,000 women, but in Connecticut, we have over 144.3 cases per 100,000 women. So just living in the state of Connecticut may be a risk factor. The good news is that we do not have higher mortality, and let me see if I can point this out. So also, the mortality from breast cancer is going down. This is a graph that shows mortality from many different types of cancer in women, and this pink line is breast cancer. So starting in 1990, there's been a steady downward trend in the death rate from breast cancer, and this is thought to be from screening and also from better treatments. So I'm not going to go through this list because you just heard it all. I'll just emphasize being a woman is the greatest risk factor. Men are also at risk, so if men see a change in the breast, they should be evaluated because they may get cancers too. And I also was going to emphasize that there are very few of these risk factors that we can modify, and we certainly recommend that people try to stay at a healthy weight and exercise and avoid alcohol, but even people who comply with all these recommendations still get cancer. So screening mammograms, we recommend that women start at age 40 and continue annually as long as they're in good health. Mammograms are good. Overall, they'll pick up 85% of breast cancers, but they don't pick up everything. And women who have dense tissue, which I'm going to show you in a minute, we may not pick up as many cancers. So additional imaging is available, especially in Connecticut. If you have dense tissue, we can do breast ultrasound and breast MRI for women who are high risk. And I just want to emphasize that if you're having a symptom in the breast, if you feel a lump, any nipple discharge, whether it's clear or bloody, pain, especially pain in one spot that's not going away, or a change in the breast shape or a change in the skin, you should not be having a screening mammogram. You should be having a diagnostic mammogram. So a mammogram is going to be much more sensitive if the radiologist knows what they're looking for. You want them to zoom in on the area in question and really make sure there's nothing going on. So this is a sample of a screening mammogram. Let me see if I can do it this way. So this is two views. These are called the cranial caudal views. and the breast is compressed up and down. So it's like we're looking down on the breast from above. So we have the right breast over here, the left breast over here. You can see the nipples in front. If we draw a line down the middle, this is the outer breast toward the underarm, and this is the inner breast in the middle of the chest. And this is a perfectly normal mammogram. This white tissue is the glandular tissue, the ducts and the lobes. So this person does not have dense tissue. The darker areas is the fat. This is the other view that's done. In this view, the X-ray plate is brought up under the underarm area. So we see the chest wall muscle. This is the pectoralis muscle. Again, we have the right and the left. And now with these views, we can see the upper breasts and we can see the lower breasts. So this is a normal mammogram. This is an example of an abnormal mammogram. This person also does not have dense tissue. I'm going to point this out. On the left side, there's a small mass here, and it's got this white spot in it. That white spot is a biopsy clip. So that was already biopsied and shown to be benign. But on the right side, you have a developing density, and all the lines are coming into it. When cancers are developing in the breast, they tend to pull the normal tissue in, so we don't like to see that. And here it is on the other view. You can see that mass. Here's the benign mass down here. So this was a breast cancer. This is an example of somebody with very dense breast tissue. So this was actually a diagnostic mammogram. So you can see the difference in how much white tissue there is. It's very hard for the radiologist to see through it. But even with dense tissue, we can see changes. And what you see here, this is a marker on the skin where this woman was feeling a mass. And you can see that right under it, it's whiter tissue, it's denser. Now, she's also had a number of benign biopsies. That's what these white spots are, they're clips. And she has a history of cysts. So she had an ultrasound, which did show lots of cysts. And the mass that she was feeling was a classic simple cyst. This is what we love to see. This has a nice smooth wall. It's black on the inside, which means it's fluid. And the sound goes through it. We see this white stripe behind it. So this is benign. We could leave it alone. The mass was bothering her, so she opted to have it drained or aspirated. But cysts in general don't have to be treated if they're not causing problems. Even with dense tissue, we can also see calcifications. So calcifications can be our earliest sign of cancer, often showing us duct carcinoma in situ, the non-invasive cancers. So you can see these little white dots here that are all clustered in all different shapes and sizes. When we see that, often the radiologist will recommend a biopsy. And I want to point out that 80% of the time when the radiologist says you should have a biopsy, it ends up being benign. So many of these will not be cancer, but this is what we look for to decide if somebody needs a biopsy. Here's another example of somebody with dense tissue. And if you live in Connecticut, when you have your mammogram, you're almost certainly having mammogram with tomosynthesis. You'll also hear this referred to as a 3D mammogram. So during the mammogram, they take little slices through the breast. So everything looks normal here, but the radiologist on the tomosynthesis slice focused in on this area, and I'm going to show you a zoomed in picture of that. And you can see almost a spider here. This is called a spiculated mass. And this was seen on the tomosynthesis. We didn't see it at all on the regular mammogram. So when there's a problem, the next step is to do an ultrasound. So this is an ultrasound of that area, and I think you can see how different it is from the simple cyst. There's this irregular margin. It shadows behind it. It doesn't let the sound go through. And it doesn't look nice and black in the middle. It's kind of gray. So this is not a fluid-filled cyst. This was, in fact, a cancer. But the next step when there's an abnormality is to do an image-guided biopsy. And we can use an ultrasound as guidance. We can use a mammogram as guidance. We can even use MRI, which I'm going to get to. This is a picture of image-guided biopsy. So you can see the needle coming right through that mass there. So the radiologist is going to take several pieces of the mass, and they're going to leave a biopsy clip behind. Here's a mammogram with a biopsy clip in place. This is the same spot. There's the biopsy clip. Here it is on the side view, which we didn't see before. Now we know where it is. If a biopsy is benign, it just stays there. Then in the future, when the woman has a mammogram, if we see the lump, we know we don't need to biopsy it because it's already been biopsied. And if it's cancer, it helps us identify where to go to take it out. So the clips are very important. So breast MRI is the most sensitive test we have for breast cancer. It picks up 98% of invasive cancer. It is not as good for the non-invasive cancers that we can see with calcifications on a mammogram. And the biggest problem with MRI is it has the highest risk of false positives. So about 16% of the time, you find something, the radiologist recommends biopsy or more testing, and it ends up being nothing. So we really don't want everybody to need a lot of biopsies, so we reserve breast MRI for the women who are at highest risk. And so right now, the American Cancer Society recommends that women who have a 20% or higher lifetime risk of breast cancer have a routine MRI, and it also can be used for problem solving. This is a normal mammogram in a woman who went for her screening. They saw nothing. She then found out that her father's sister had breast cancer, and his sister was tested and carried a BRCA2 mutation. So of course we inherit our genes both from our mother and our father. So this woman was tested and she also carried the mutation. So we had her go for an MRI. Now MRI, there's about 1,500 images with an MRI, so I can't show you them all. I don't want to. MRI is done with contrast, so you need an intravenous. And this view shows us, it's called a subtraction view. We only see where the contrast is in white. So down here, you see her heart. The contrast is flowing through the vascular system. Cancers make blood vessels, so they light up with a contrast. So you see the green arrow is pointing to this blush of contrast. So we found this early cancer because she's having an MRI, and probably it would have taken longer to see. So it can be very helpful. Here's another situation where it can be helpful. This was a very young woman who had a family history who went for her first screening mammogram. You can see she has very dense tissue. The radiologist thought there might be some distortion in the upper part of her left breast. So she was called back, she had multiple views, she had ultrasound, nothing could be found, but they thought, well, maybe you should come back in 6 months. So she was referred to me just for discussion, and because she had a family history, I suggested that she go for an MRI, and very interestingly, again, here we see the heart, we see the left breast and the right breast. The left breast was normal, but she had this small cancer in the right breast. So it's very important that people who are at elevated risk and have dense tissue have additional imaging, or at least discuss additional imaging. All right. So to summarize breast imaging, all women should have an annual screening mammogram starting at age 40. If you have a problem, diagnostic mammogram or ultrasound. If you have dense tissue, ultrasound or MRI. Most abnormalities are not cancer, but if there is an abnormality, you should have an image-guided biopsy with placement of a clip. Because if it's benign, no surgery is needed, and if it's cancer, we can plan appropriately. So let's talk about breast cancer. So when I first see somebody who's diagnosed with breast cancer, and with breast cancer, usually women are gonna see the surgeon first before the oncologist. That's why we're speaking in this order. We're gonna think about what type of cancer is it, what does it look like the stage of the cancer is, and what should the first treatment be? Should we start with surgery or should we start with other treatments? So to understand where we've come from and where we're going in breast surgery, it's helpful to look at the history. This is one of my favorite stories. So William Stewart Halsted lived in the late 1800s and early 1900s, and he was a famous surgeon, and his theory was that breast cancer started in the breast and grew and then spread through the lymph channels to the lymph nodes, and from there it would spread to the rest of the body. So a story of sequential spread. So he pioneered the radical mastectomy. So this is a picture from an atlas of surgery, and what you see here, pointer, the surgeon is removing the breast, all the skin of the breast was removed, all the muscle from the chest wall was removed, and all the lymph nodes were removed from under the arm. It was an extremely radical procedure, but it was thought to be life-saving. This is a picture of a woman who had a radical mastectomy. Often you needed a skin graft to close the skin because so much skin was taken. You can see the deformity of the chest because the muscle is gone. So really very radical and disfiguring, but hopefully curative. So fast forward, in the 1960s, physicians who were treating women with breast cancer realized that women who seem to have stage 1 breast cancer, those are small tumors, no cancer in the lymph nodes at all, up to 30% of them were still dying of breast cancer. So clearly, if this theory of sequential spread is correct, they shouldn't be dying, so something's wrong with it. So in the late 1950s, the NSABP was formed. This is the National Surgical Adjuvant Bowel and Breast Project. And this is Bernard Fisher, who was the chairman of the breast arm. And they came up with a theory that breast cancer was a systemic disease as soon as you had invasive cancer. So in other words, as soon as you had invasive cells, the tumor could have spread through the blood vessels. It didn't have to spread through the lymph channels and could be in other organs. And if that's the case, it's not so important to do aggressive surgery on the breast. It's more important to do aggressive systemic therapy to kill any cells that might be left in the body. So they did a lot of prospective randomized controlled trials. Now, these are considered the gold standard in medical trials. So they sign up participants and they break them up into similar groups so they have similar demographics, similar ages, similar tumor sizes, and then they randomly assign them to treatments, and then you can compare outcomes without bias. And the NSABP has enrolled over 100,000 women in these trials. So one good thing about it being such a common disease is we've really studied it well. So the first study they did is called BO4, and in this study they enrolled over 1,000 people. They all had breast cancer that could be operated on. None of them were thought to have any cancer in their lymph nodes, and they divided them into 3 groups. One group got the standard at the time, the radical mastectomy, and the other 2 groups got something called a total mastectomy. In a total mastectomy, the breast tissue is removed, but the muscle is kept intact. They didn't take all the skin, and they didn't take any lymph nodes. One of the groups that had the total mastectomy had radiation to the lymph nodes. So these were the 3 treatment groups. So this is just a picture of somebody who had a total mastectomy. You can see it's less disfiguring. And these were the survival curves. So what we're looking at is overlapping curves. Basically, there was no difference in survival in any of the 3 groups, which was really quite remarkable to people. And what this means, what was noted was 40% of the women who had a radical mastectomy and had their lymph nodes removed had cancer in their lymph nodes. So we assume, because they were all equal groups, that about 40% of the women in the other 2 arms also had cancer in their lymph nodes, and taking them out didn't make a difference in survival, which is, we all think if there's cancer, we have to get it out, we have to get it out. But it really made absolutely no difference. This study was done in the 1970s. It was originally reported in 1977. This is 25 years of follow-up in 2002. The next study that was done, BO6, in the 1980s, then compared, they said, well, if we don't have to do a radical mastectomy, maybe we can even do less. So this study compared the total mastectomy with a lumpectomy. Again, 3 groups. One of the groups also had radiation after lumpectomy. Now, all of these women did have lymph nodes removed, and the reason was not because we thought it would improve survival, but it was for prognostic information. We know if women have cancer in their lymph nodes, with each lymph node with cancer, they have a worse prognosis. So women in this study who had cancer in their lymph nodes received chemotherapy. And here are the survival curves here. Exactly the same again for all three groups. So there was one difference though. The women with lumpectomy that didn't get radiation had a much higher risk of cancer coming back in the breast, 30 to 40%. Whereas women who had a lumpectomy with radiation, it was more like 10%. So after this study, women had a choice of a mastectomy or a lumpectomy with radiation. And so in a very short period of time, we went from a radical mastectomy being the standard of care to a lumpectomy with radiation. So today, of course, women have a choice of a lumpectomy or a mastectomy. Some reasons that women still have mastectomies is if there's too much disease in the breast to remove it all with a lumpectomy. Women who have a genetic predisposition might choose to have a mastectomy, not because it's better for survival, but to prevent another cancer from coming up because they might be at higher risk. And then some women prefer to have mastectomy based on their own experiences. So I see some women who've had multiple benign biopsies, and they just, when they get diagnosed with cancer, they don't want to have any more mammograms. But I always counsel people, don't choose a mastectomy because you think it's going to improve survival. And you can't choose it because you think you're going to avoid chemotherapy, because what we do to the breast has no effect on the rest of the body. So I'm gonna go through lymph node surgery. I'll try to move it along a little bit. We routinely remove lymph nodes to get the prognostic information. And so after those studies, we took out 2/3 of lymph nodes, and many women, 30 to 40%, got lymphedema. This is a woman in the radical mastectomy era who had severe lymphedema of the arm. It's extremely morbid disease. It's hard to find clothes, it's hard to use the arm normally, so really very worthwhile to avoid lymphedema. And remember that taking out lymph nodes doesn't help survival. So in the 1990s, the sentinel node biopsy was actually developed for other types of cancer, but people started using it for breast cancer. So this is a mapping procedure. So tracers are injected into the breast, radioactive tracer or blue dye or both, and those tracers travel through the lymph channels to the lymph nodes the way cancer would travel if it was going to travel. So it's a mapping procedure. The dye going to the lymph nodes doesn't mean there's cancer there, but it's allowing us to just take a couple of lymph nodes that are most likely to have cancer and leave the rest of the lymph nodes alone. And once again, we like our randomized control trials. There was a trial that confirmed that this was 97% accurate, and it could detect the correct lymph nodes 97% of the time. And then there was a trial, so when we first started doing this procedure, if women had cancer in these sentinel nodes, we would take more. There was a trial called Z11 that compared taking more versus not taking more, and we should have known from our original trial at B04 that there would be no difference in survival. And there was no difference in survival or local recurrence. There was just a big difference. The women who had more lymph nodes removed had more lymphedema of the arm. And so now we rarely do lymph node dissections for women who don't have a lot of cancer in their lymph nodes. So now, and Dr. Fong is going to talk to you more about this. We have other ways to determine the prognosis of many cancers. So some women may not need to have lymph nodes looked at all. They may not even need a sentinel node biopsy. So back to what I was saying, when we make the diagnosis, now that you know the history of the treatment of breast cancer, the type of breast cancer is very important. There are 3 receptors that are tested on all breast cancers. 2 of them, estrogen and progesterone, are hormone receptors. And if they're positive, it tells us that we can target those receptors with anti-estrogen treatment, which is a pill. And so they're candidates for that treatment. The 3rd receptor is HER2. So this is an oncogene that's been identified in just under 20% of cancers. These tend to be more aggressive, and we have a targeted treatment for them, and we usually give people chemotherapy with HER2-positive cancers. What we don't love to see is triple-negative breast cancers. Triple-negative meaning all 3 of the receptors are negative. Those tend to be more aggressive cancers, and we usually treat those with chemotherapy. And this is just a cellular array that shows you the diversity of breast cancer. So we have always treated it very much the same. And so this column over here is normal breast tissue, but each of these rows is a different type of breast cancer. So really, there's quite a bit of diversity. So we tried to personalize the treatment more. So after we determine the type of cancer, we think about the stage, and this is just a broad overview of staging. The staging system is very complex now, but basically stage 0 is the non-invasive cancers. Stage 1 are small tumors that are 2 centimeters or less, and the lymph nodes look normal. Stage 2 are bigger tumors, bigger than 2 centimeters, or with lymph node involvement. Stage 3 are usually much bigger tumors, often invading into the skin or the muscle, or they have quite a bit more lymph node involvement. In stage 4, we really hope not to diagnose people at stage 4. That's when the disease has spread beyond the breast to other organs. So if I see somebody and it looks like they're stage 3 or stage 4, I'm gonna send them right to my medical oncology colleagues. For stage 1 and 2 and 0 patients, we're gonna think about doing surgery first. So one question we have is, should I do surgery or should they have other treatments first? So if we know somebody's gonna get chemotherapy, it's actually helpful if the tumor's in the breast, you can see if the chemotherapy is working, because the chemotherapy can make the tumor melt away. So this gives us prognostic information and helps us know what to do. And I'm not gonna spend too much time on this because I think Dr. Fong is gonna talk to you about it more. So in the people we are gonna do surgery first, so if we're not planning on chemotherapy, we have our choices as we discussed. Lumpectomy, you'll hear it called a partial mastectomy, wide excision, or we can do a mastectomy. And now we have a lot of plastic surgery techniques to get better cosmetic outcomes. So we can do plastic surgery with a lumpectomy, and we can do reconstructions. And I have to thank my one of the plastic surgeons that I work with a lot, Dr. Sharif Jandali, for these pictures. He shared with me, I don't usually take pictures of my patients after lumpectomy, so I can't show you any, but the plastic surgeons always take pictures. So this is one of our patients who had cancer in the left breast, and she had too much cancer to preserve the breast, so she opted for a bilateral mastectomy. So she had incisions under the breast. Some people call this hidden scar surgery. So there's an incision right underneath. All the breast tissue was removed and it's replaced with an implant. So you can see we get some nice cosmetic results, which helps emotionally when you have to lose the breast. Another way to do a reconstruction is with the body's own tissue. So this is a DEEP flap. So DEEP stands for deep inferior epigastric perforator flap, which you don't need to remember. But basically, they take the abdominal fat and they keep the blood vessels intact, and they attach the blood vessels to the blood vessels in the chest so that it keeps its blood supply. So this requires a very long surgery. It's at least 10 hours in the operating room and a stay in the intensive care unit afterwards to make sure that the tissue is getting perfused with blood. And it requires a second procedure to shape the breast. This woman opted for this type of reconstruction. A lot of women don't want to have implants in. Long-term implants can rupture, in which case they have to be replaced 10 years later. So this is a nice option for somebody who is healthy enough and willing to have this major surgery. So this is a third type of reconstruction that is often called the Goldilocks reconstruction. And it's Goldilocks because it's not too much. There's no implant. There's no 10 hours in the operating room. But it's not too little. It's not just a scar across the chest. So here, the breast is created from just the skin and the fatty tissue right under the skin of the breast. You have to have a larger breast to do this. And the nipple and areola were grafted on, skin grafted on later. So it gives a woman something that looks like a breast, so you can feel more whole. Emotionally, it's easier. And then finally, this is a woman who had a large tumor of the right breast. And if we took it all out with a lumpectomy, she would be very uneven. So she opted for what we call oncoplastic reconstruction. So I took out the tumor, and the plastic surgeon reconstructed the breast and pulled in normal tissue where the tumor was removed, and then reduced the other breast to match. So these are all good options in breast surgery today. So just to summarize, we start with imaging and a needle biopsy to assess the tumor biology. We decide, are we gonna do surgery first, or are we gonna do other treatments first? We can do hormone therapy first, which can help shrink tumors also. And if we're doing surgery first, we have the option of lumpectomy or mastectomy. We decide if we're gonna evaluate the lymph nodes. And then after surgery, more treatments. Many women after a lumpectomy still get radiation. There's radiation after mastectomy also in women who have cancer in their lymph nodes. And of course, women who are candidates for hormone therapy, we give them that. So this is my last slide, just to get back to my takeaways. Remember that everyone is at risk. Everyone should get screened. Be aware of any changes and bring them to the attention of your physician. Imaging can miss things, so even if your imaging is negative, don't assume nothing's wrong. See someone and have it evaluated further. And when it comes to surgery for breast cancer, less is really just as good as more. So with that, I'm gonna turn you over to Dr. Fong, who's gonna tell you about the really exciting progress in breast cancer treatment.
All right, good evening, everyone. First of all, thank you, Dr. Altbaum, for inviting me to speak here tonight. I think this is an extremely important topic for all of us to know about, the advancements in diagnosis as well as systemic treatment in breast cancer. So this is just a general, overview of the timeline of breast cancer advancements. We've come a long way since the 70s, and that's when chemotherapy really started becoming widely used for breast cancer, followed by endocrine therapy, or other words, anti-hormone, anti-estrogen therapy. Then in the 90s, targeted therapy was introduced, especially for HER2-positive breast cancers. And nowadays, tumor profiling, genomic testing, as well as further improvements in targeted therapy are allowing for more personalized, more individualized medicine, which means that treatments are becoming more effective at improving survival rates, at improving quality of life, while decreasing the risk for systemic toxicities and side effects. So before I actually go through a lot of these developments and breakthroughs, it's important to just understand the basics of breast cancer. So just quickly, because I know that we already talked about this, but the breast has lobules and ducts. Lobules are the small sacs that make the breast milk, and the ducts are the small tubes that carry breast milk from the lobules to the nipple. So let me just turn on the pointer. Okay, so some breast tumors are benign here, as you can see, meaning they're not cancerous, they're not going to spread to other parts of the body, but there are other tumors that can be malignant or cancerous. They do have the potential to spread to surrounding tissues. They do have the potential to spread to other organs through the lymphatic system, through the blood. So just to, again, start with this progression, briefly about atypical hyperplasia. These are benign, non-cancerous breast lesions. They involve the overproliferation of abnormal cells in the ducts or the lobules of the breast. And so you might hear of atypical ductal hyperplasia, atypical lobular hyperplasia. These are high-risk lesions that can increase the risk of developing into breast cancer over time. And that risk is a 30% lifetime risk. And so in other words, for every 100 women who are diagnosed with atypical lesions, atypical hyperplasia, 30 can be expected to have breast cancer in their life. So the question is, how can we reduce the risk? Chemo prevention, this is not chemotherapy, even though it has the word chemo in it, refers to medications that are used to reduce the risk of developing breast cancer. And that includes the use of endocrine therapy, such as tamoxifen, raloxifene, as well as aromatase inhibitors that include anastrozole, letrozole, and exemestane. The percentages that you see over there on the screen, okay, means that basically we are reducing the risk of breast cancer happening by, for instance, 50%, upwards of 50% with these medications. And so earlier you heard basically that 1 in 8 women, so about 13% of women can be diagnosed with breast cancer. Now, earlier I said that the lifetime risk for those women who have atypical hyperplasia, their risk is 30%. If you take endocrine therapy, though, that reduces that risk by half, so close to 15%, so basically close to that 13% population. I'll talk more about endocrine therapy in a little bit, but this just goes to show that, besides early detection as well as screening, this is a way to decrease the risk of developing breast cancer in those who are at high risk of having it. So we already heard too that the earliest breast cancers are called in situ or in situ cancers. This means that the tumor has stayed inside the place where it first formed, for instance, those ducts. They haven't yet spread to nearby tissues. If they're only found in the milk ducts, then this is what's called ductal carcinoma in situ, DCIS. But once it has broken through the ducts and invaded the breast tissue itself, then that's when it becomes an invasive breast cancer. LCIS, lobular carcinoma in situ, does have a similar name, but it is not actually cancerous. It's considered a risk factor similar to atypical hyperplasia in terms of people being at increased risk of developing breast cancer. It really just refers to abnormal cells in the lobules of the breast. And when tumors, like I said, spread to other areas outside of the breast, through the blood and the lymph vessels, that's when, unfortunately, it is metastatic disease or stage 4 breast cancer. So for the sake of time, I'm just going to really focus on the diagnosis and treatment of the earlier stage invasive breast cancers. Okay. So first of all, this is a breast cancer cell, a very simplified picture of it. Breast cancer cells are tested for certain biomarkers, including estrogen, progesterone, and HER2 receptors. And so there are distinct subtypes based on which receptors are or are not expressed. And that then helps individualize one's treatment plan. So for instance, if breast cancer cells express hormone receptors like estrogen, progesterone receptors, then we call it hormone positive or hormone dependent breast cancers. Whereas if they express, say, HER2 receptors, then you might hear HER2 positive breast cancer. And if they don't express any of these, then you might hear triple negative, hormone negative and or HER2 negative breast cancers. So from the medical oncology standpoint, what does it mean if breast cancer is hormone positive, HER2 positive or negative? What kind of significance does this have? So again, another simplified diagram, but in terms of hormone receptor positive breast cancers. So breast cancer cells here, they produce these hormone receptors. These are protein receptors, and they can be estrogen and or progesterone receptors. And so when estrogen here binds or attaches to that estrogen receptor, it allows the cancer cell to continue dividing, to continue growing. In terms of HER2 positive breast cancers, it stands for human epidermal growth factor receptor 2. And it's actually a protein that does normally appear on healthy breast cells, but at a lower number. And so for HER2-positive breast cancers, there's an overproduction of these receptors, causing those cancer cells to continue to grow and divide rapidly. So here you have your various subtypes of breast cancer. First, we start with all the cases. We divide it into hormone receptor negative or hormone positive. And then depending on whether or not they express HER2 receptors, you have these 4 down here. With your triple negative, like I said, not expressing any of those receptors, it makes up to 15% of all cases. And then you have the most common being your hormone receptor positive HER2 negative breast cancers. And so the majority, about 70 to 80% of these breast cancers express hormone receptors here, as you can see. These types of cancers have a more favorable prognosis. They have significantly improved outcomes compared to those who are hormone receptor negative. So let's just start with the case so that we can get a better idea of how this works. So I had a patient who was 67 at the time when she had a screening mammogram that showed a small left breast mass. It was about 1 centimeter. She did have a biopsy that did show invasive ductal carcinoma, or IDC for short. And again, that means that those breast cancer cells have broken out of the milk ducts, invaded the breast tissue itself. It was hormone positive, so ER, PR positive, greater than 90%. So what that means is that when the pathologist looks at the biopsy, looks at the specimen, they stain the specimen for these receptors. And basically, anything that is 1% up to, say, 100% means that it's hormone receptor positive. So it's looking at the percentage of these tumor cells that express these hormone receptors out of 100 tumor cells. So that's how you get the percentage. And clearly, the stronger the hormone receptor positivity, that means that the more likely they are to respond to, say, endocrine therapy or anti-estrogen therapy. The Ki-67 was 5%, Nottingham grade was 1. I'll explain what that means in a little bit. And then she had surgery, which showed, again, IDC, 1.2 centimeters, so small, early stage. And 1 lymph node was removed, showed that there was no evidence of cancer having spread there. So the reason why I go over these specific points is that tumor characteristics predict which patients are likely to benefit from specific types of therapy. And so we look at the tumor size, how big the mass is. We look at which receptors are or are not expressed. We look at the tumor grade, the Ki-67, and we look also at whether or not cancer has spread to those lymph nodes. So the Nottingham grade is pretty important in telling us how aggressive the cancer is. It is prognostic in terms of breast cancer recurrence, metastasis, as well as treatment response. It's based on 3 factors, as you can see here: tubule formation, meaning how much the tumor looks like the normal cell structure, like the normal ducts. Nuclear pleomorphism, how different the tumor cells look from the normal cells, as well as mitotic activity, how quickly those cells are dividing. So in other words, we're comparing those breast cancer cells to normal breast cells. And so it gives us an idea of how aggressive those cells are. And we give it a grade that goes from 1, well differentiated. Those breast cancer cells look more like the normal breast cells. They're slowly dividing, okay? Grade 2 is moderately, right in the middle. And grade 3, means poorly differentiated. Those cells look nothing like the normal breast cells. They're rapidly dividing, very aggressive. The grade, for the most part, goes hand in hand with what's called the Ki-67, which is given as a percentage. It is a protein that's found in actively dividing cells. So as you can imagine, right, a higher Ki-67 means that there's a higher rate of cell division. And that means that this is likely a more aggressive tumor, a higher risk of recurrence and/or metastasis. So the other thing, too, is that it can also help predict treatment response. People might ask, well, what defines a high Ki-67? Generally, it's anything that is above 20%. And the reason why I say that is because that is really the threshold that's used in clinical trials to see if patients are high risk, if they would benefit from additional treatments in the long run. A high Ki-67 too, in terms of predicting treatment response, has been associated with a higher likelihood of, say, triple-negative breast cancer patients who receive neoadjuvant, meaning treatment before surgery, in terms of achieving what's called pathologic complete response, meaning no evidence of, say, residual cancer on that surgical specimen from their treatment. And so studies have found that actually a high Ki-67 in those patients who have triple-negative breast cancer who get neoadjuvant treatment, they respond very well. They tend to have high PCR rates in that setting. So back to case number 1. So just quick summary, right? This is an early stage breast cancer, like I said, small 1.2 centimeter tumor. One lymph node didn't show any evidence of metastatic disease. The Ki-67 was very low, 5%. It was a grade 1 well-differentiated breast cancer. So what happens next in terms of systemic treatment? So if hormone receptors are present in breast cancer cells, then that means that one would benefit from getting what's called endocrine therapy or anti-estrogen therapy. And the higher the estrogen and progesterone receptor expression, the higher the benefit. And endocrine therapy has been shown to reduce the risk of a breast cancer recurrence by nearly 50%. So it provides significant benefit in this case. There are 2 types of endocrine therapies that's typically used in the adjuvant setting, again, meaning after surgery. Tamoxifen, or TAM, as well as aromatase inhibitors, or AIs. You might hear me call it that, okay? This is a treatment in the form of a pill that's taken once daily for at least 5 years. They work differently, but they do have basically the same end goal. So tamoxifen works by blocking the estrogen receptor so that estrogen can't bind and allow the cancer cell to grow. It's effective in both pre- and post-menopausal women. Whereas aromatase inhibitors, they suppress an enzyme called aromatase, which is produced in those who are in menopause. So it's made in muscle, it's made in fat, it's even made from the breast tissue itself. And so this enzyme, aromatase, converts other hormones, like androgens and testosterone, into estrogen. So the aromatase inhibitors suppress that estrogen production. And so this is only effective in postmenopausal women. Now, if it's taken by a premenopausal woman, okay, we know that the ovaries are still on. They're functioning. They're what's producing the estrogen. And so it can be dangerous for those premenopausal women to take AIs because it can cause basically a compensatory physiological response. It can make those ovaries produce more estrogen than it should. So actually, and just to finish off another point too, endocrine therapy is the mainstay of treatment for hormone-positive breast cancers. Like I said, it's used in chemo prevention, it's used as risk reduction for those high-risk lesions, but it's also used in metastatic stage 4 breast cancers in combination with other treatments. But again, it is the mainstay of treatment, so it's a very important medication for those who have hormone-positive breast cancers. So question comes though, well, we hear all about chemotherapy, right? But what about chemotherapy for this type of breast cancer? And this is where the Oncotype score comes into play. It looks, basically, it's a special test, okay? It's a sample of either the biopsy or the surgical specimen is sent to a special lab. They look at 21 genes from the cancer cells themselves, and they come up with this score to identify those people who would benefit from getting chemotherapy. It helps determine the significance of the chemotherapy benefit, and it provides that individual's risk of distant recurrence. So this is an example of what we call tumor profiling or genomic testing that has really changed also the treatment landscape of breast cancer. This is a sample report. So someone had a score of 4 that translated to a low risk, a 3% risk of distant recurrence, meaning cancer popping up elsewhere in the body at almost a decade from now if they're only on endocrine therapy alone. And so those patients would not benefit from getting chemotherapy with this low score. So just to focus on this top row first, okay? Basically, for someone who is older than 50, who does not have any cancer in their lymph nodes, or who's postmenopausal with even 1 to 3 lymph node involvement from their cancer, we know that anyone who has a score of 25 or below would not benefit from getting chemotherapy. And so this goes to show that the majority of these early breast cancer patients can be spared chemotherapy, which again was a huge game changer when it came out. Anyone, though, who has an oncotype score of 26 or higher, it doesn't matter your age, it doesn't matter if lymph nodes are involved, it doesn't matter about your menopausal status. All of these patients would benefit from getting chemotherapy because that risk of it coming back elsewhere in the body is very high. So for my patient, her oncotype score was low, it was 14. Chemotherapy wasn't recommended. She had radiation though, and then she started anastrozole with the plan to complete 5 years of therapy. So a pretty simple, sorry, not simple, but a pretty straightforward case in this regard. So this also tells us that menopausal status for hormone-positive breast cancers does matter in treatment planning. Just to jump to a different case, okay? I had a 46-year-old woman who was premenopausal at the time. She had a right breast mass that was also small, 1.2 centimeters. Biopsy showed IDC. It was strongly hormone positive or hormone dependent. Like the other case, the Nottingham grade was low at 1. The Key 67 was 3%. She went on to have surgery though, still showed IDC. The tumor was small. 2 lymph nodes were removed, but unfortunately, one of them did show lymph node involvement from the cancer. She had an oncotype score checked, which was low at 7. So what does this mean? Does she need chemo? Does she not need chemo? Looking at the bottom 2 rows here, okay? For anyone, studies have shown that for anyone who is 50 years or younger with no nodal involvement, if they had a low risk score of 15 or below, they did not benefit from getting chemotherapy. An intermediate risk score for this population was considered between 16 to 25. So there needs to be a discussion between the patient as well as the physician in terms of, okay, should I get chemotherapy or not, right? If I see here that someone came to me, they had a score of 16 and it was about a 0.6% benefit, we have to talk about sometimes, the risk of giving chemotherapy might be higher than the benefit, especially if your, benefit here is so low from having chemo. For premenopausal women who did have any lymph node involvement, again, and it doesn't matter, how many lymph nodes, doesn't matter what, the oncotype score doesn't matter. All of these women, based on this trial called R-Exponder, did show that women did have a significant benefit from getting chemotherapy. And I know you see here, there might be a small chemotherapy benefit in your eyes, like 2.3, 2.8%, but this was actually meaningful. And if you think of these younger women, right, that risk is much higher for that breast cancer to come back. So you want to reap, every benefit that you can, and that might include getting chemotherapy. So this is the standard treatment recommendation today, especially for premenopausal women who do have lymph node involvement. So she was recommended chemotherapy, but there's been question about that, whether the benefit is really from the chemotherapy itself or from the ovarian suppression effect of the chemotherapy. Because remember, these cancers are hormonally driven. They're hormonally dependent, and chemotherapy, its side effect is that it basically turns off the ovaries. It has that suppression effect. And so there's actually a trial right now, the Offset trial, which we have open at Norwalk, that's evaluating this in premenopausal women who have a high oncotype score, who don't have a high oncotype score, but they do have lymph node involvement, or they have an intermediate risk score with no lymph node involvement. So we're looking at endocrine therapy, with ovarian suppression versus chemo with ovarian suppression with endocrine therapy. And this is just like Dr. Capassi's talk, where sometimes less is more, and we're trying to head in that direction. So the oncotype score, DX recurrence score, is a great example of this. It allows for effective targeted interventions rather than over-treatment with, say, chemotherapy, while maximizing the benefits of treatment for our patients. And hopefully the Offset trial too, we'll have great results with that in terms of, hey, can premenopausal women forego chemotherapy? So CDK4/6 inhibitors, what are they and who can take them? So this is a pretty complicated diagram, but just to simplify it, we have various pathways that can basically help a cancer cell grow and divide if they're dysregulated. And so imagine that this here is a cancer cell. These are the pathways right here. You can see RAS, RAF, MEK, ERK, PI3K, AKT, mTOR. If there are any mutations, if there's any dysregulation, that can allow the cancer cell to continue to grow and divide and obviously spread. It uses a pathway called CDK4/6. And basically, turning on this pathway allows this E2F transcription factor to make more of these cancer cells. One way of doing that is through estrogen in hormone-positive breast cancers. So estrogen binds to the estrogen receptor and it activates this pathway. And that's how, it's an important pathway for cancer cell growth and development. So that's why we have these CDK4/6 inhibitors to target that pathway. And that includes 3 drugs, which you may or may not have seen on commercials and things like that: Verzenio, Ibrance, and Kisqali. These are very, very popular medications nowadays, shown to have significant benefit in those women who have advanced hormone-positive disease. So all 3 of these drugs are approved as first-line treatment in combination with endocrine treatment for metastatic breast cancer. It's first line. And so like I said, endocrine therapy is the mainstay of treatment for this type of breast cancer. Now for early-stage breast cancer, there are 2 that are approved. Verzenio, which was approved in 2021, so still relatively new, but Verzenio was approved for those who had lymph node involvement as well as high risk of recurrence. It depended on the tumor size, it depended on if there are lymph nodes involved, as well as that Nottingham grade. More recently, Kisqali, or ribociclib, is approved for stage 2 and 3 disease in those who also have a high risk of recurrence, and that was approved at the end of 2023. They have not been compared head-to-head, so you can't say that one is better than the other, but they are both very effective at decreasing that risk of breast cancer recurrence by upwards of 40%. So moving on to HER2-positive breast cancers, these make up about 15% of breast cancer cases. They tend to grow, they tend to be a bit more aggressive and spread faster than the other subtypes, but they respond really well to anti-HER2 treatment, those treatments that specifically target that HER2 protein receptor. And so this is just a list of very common drugs that are used: Herceptin, Perjeta, Kadcyla, and HER2. And there are also oral medications out there as well. So as Dr. Kapasi mentioned, there are times when neoadjuvant treatment, again, meaning before surgery, treatment before surgery, would be recommended. And those who have locally advanced breast cancers, as well as earlier stage, even stage 2, HER2-positive breast cancers, might be recommended neoadjuvant systemic therapy. That's a combination of chemotherapy plus anti-HER2 treatment. The goal of treatment isn't just to improve surgical outcomes. It's not just to, decrease, surgical morbidities, but it's really to get to induce a tumor response before surgery, because those complete response rates can be very high, upwards of 60%, meaning that there's no evidence of any cancer left, by the time of surgery, which is excellent, okay? And it also provides information about treatment response, because it can affect treatment recommendations after surgery as well. So case number 3, a young 53-year-old woman, she had palpated or felt a right-sided axillary mass, so a lymph node, for about 2 to 3 months. She had imaging that basically confirmed those findings, that it was abnormally enlarged. And she had a biopsy that showed IDC. It was hormone receptor negative, HER2 positive. As you can see here, the grade was a bit higher, right? It was grade 3. Ki-67 was also high at 20%. And so she started neoadjuvant treatment with chemotherapy as well as Herceptin and Perjeta. She underwent surgery and she was found to have a complete response, which was excellent news. She had radiation after that, and then she was put on a year total of what we call anti-HER2 maintenance. And the reason why this is important to mention is, again, just like endocrine therapy is the mainstay for hormone-positive breast cancers, basically these anti-HER2 treatments, these targeted therapies, are the mainstay of treatment for the HER2-positive breast cancers. Now, if she had residual disease, right? Earlier I said that treatment response can be determined by giving neoadjuvant treatment. That would actually affect what treatment recommendations would be offered afterwards as anti-HER2 therapy. There are stronger, more aggressive treatments that can decrease the risk of breast cancer recurrence, especially with those who have residual disease. So your triple-negative breast cancers, again, they don't express any of these receptors. And so they account for about 10 to 15% of all breast cancers. They are more commonly found in those who are younger than 40, so very young women, African American women as well, or those who have a positive BRCA1 mutation. And just to put it into perspective, right? Less than 10% of breast cancers are really associated with these BRCA mutations, but up to 20% of triple-negative cancers actually have the BRCA mutation, especially the BRCA1, which is why those with triple-negative breast cancers should always be offered genetic testing. It's really important to know about their BRCA status because it can have therapeutic implications. These cancers tend to behave more aggressively compared to the other types of breast cancer. And they tend to be diagnosed clinically, meaning people might feel them themselves or a physician might feel it on exam versus on breast imaging. It is challenging to treat, though, because they don't express any of these hormone or HER2 receptors. So chemotherapy, unfortunately, is the mainstay of treatment. But in 2020, another change in the treatment landscape, immunotherapy was introduced. And I know that Dr. Frank sort of started off this lecture series, but just to, again, go over it for those of you who may have missed it, the immune system has what we call T cells. These T cells are able to recognize, say, foreign antigens. Say they can attack viruses, right? They can find tumor cells as well because they're foreign and basically attack them and kill them. They use what's called a T cell receptor and they attach to the antigen that's being expressed on whatever is expressing it. And that's how they are able to kill those tumor cells. There is a PD-1 receptor, though, on these T cells, and basically they act as brakes, right? You don't necessarily want to rev up the immune system either, because that's how you get, say, autoimmune diseases and things like that. And so, unfortunately, tumor cells, cancer cells, are smart. They have also PD-L1, what's called PD-L1 receptors, that can bind to these brakes on the T cells, that can bind to the PD-1 receptors and basically hide and not be killed by the T cells. Now, immunotherapy, the way it works, you have anti-PD-1 or anti-PD-L1. So Keytruda, for instance, or pembrolizumab is an anti-PD-1 drug that basically binds to this PD-1. That allows the T cell, though, to recognize those cancer cells and then kill them. And there's also other immunotherapy like PD-L1 that binds to the cancer cells as well, and that can also kill them that way. So as of 2019, we saw that Keytruda, or Pembro, was FDA approved for treating all types of cancers, but not breast cancer. And so in 2020, this was a game changer again. In 2020, Keytruda was also introduced to help treat early triple-negative breast cancer before surgery. Combined with chemotherapy, those patients had a significant response, and so this is what's used in treatment. And sorry, just for the sake of time, just quickly, I had a young female, 36 years old. She felt a right breast mass, and basically she was found to have a 5-centimeter mass, enlarged axillary lymph nodes, had a biopsy that confirmed a triple-negative breast cancer, and the Nottingham grade, as you can see, was high. The Ki-67 was very high at 70%. She was on this treatment, chemotherapy with immunotherapy. She also had, like I said, a BRCA1 mutation. That's why it's important to have genetic testing. And basically had surgery. She had a complete response. And per the protocol, she completed immunotherapy maintenance afterwards. So the other thing too now is also immunotherapy is given in combination with chemotherapy as first-line treatment for metastatic triple-negative breast cancer with high expression of PD-L1. Just quickly though, this is actually wrong because recently at our annual Cancer Society meeting in Chicago, Keytruda is actually found to be better with a targeted drug therapy versus chemotherapy. So again, this is showing that, you know, less is more basically. We're coming a long ways with treatment. All right, go ahead, okay. So going forward, just genetic testing, like I said, had revealed this BRCA1 mutation. And so in terms of genetic testing and genomic testing, it's important to differentiate between the two. Genetic testing is evaluating for any mutations that are inherited or hereditary, that's passed down generation to generation. Genomic testing identifies mutations that develop in the cancer cells themselves, and that can be tested through the biopsy, through the surgical specimen, and also through what we call liquid biopsy, through blood. I'm not going to go through this slide, but these are all the targetable mutations that, you know, can be found in breast cancer. There are more than that, but I'm just fitting what I can in one slide. And so just going back to that one patient who had the BRCA1 mutation, another treatment that was recommended for her was something called olaparib, a PARP inhibitor, after completion of her treatment, because this was also shown to improve what's called disease-free survival, meaning living without breast cancer recurrence. And this is also why, again, you know, you see women, you see men too, living longer after having been diagnosed with breast cancer. So that's why you see all those survivors. And this is just really to summarize what I, went through. This is, breast cancer treatment, diagnosis, everything. There's a multidisciplinary approach. You're looking at the clinical information. You're looking at someone's age, their menopausal status. You're looking at the pathology. For instance, if lymph nodes are involved, the receptor status, the Ki67. And you're also doing molecular analysis, meaning you're looking at the genomic profile, for instance, the oncotype score, to really help individualize that treatment plan for that patient. So advancements in breast cancer have led to more effective, more personalized treatments, and so we are nowadays improving quality of life. We're improving overall survival rates, and this is why I love doing what I do, because the future of breast cancer care holds great promise. There's ongoing research. We're having even more effective, more targeted therapies and personalized treatments, as well as improving early detection and prevention strategies. So, thank you very much.
That was a lot of information. Anyway, we're gonna have a Q&A. We have a little time. I will ask you that if you're interested, please go over to the microphone, because they are filming this, and don't do it from your seat, do it from the microphone. If you have a question, try to keep it more generalized, not specific to a particular problem you have. They will be here afterwards if you have a specific question, but if you have a general question that you'd like to know, please step up to the microphone, and we'd be happy to try to field that for you.
Hello. I may have misunderstood because there was a lot to take in, but are there any cases where chemotherapy with adjuvant Herceptin would be used in a HER2 negative cancer?
No. So there are what's called HER2 low breast cancers now. I didn't cover that because that would be too in depth. But for those people who might have metastatic breast cancers that are HER2 low, sometimes we can use anti-HER2 treatment to target and treat those breast cancers. But in terms of adjuvant breast cancer therapy for HER2 negative breast cancers, it is not standard of care.
Any other questions?
Firstly, I want to say this was extremely interesting. I felt like I was in a medical school here trying to absorb everything. My question is, excuse me, I just happened to read an article in New York Times, I think it was 2 days ago, I forgot to bring it, not very large, but apparently AstraZeneca is doing some research on detecting breast cancer through blood tests. Did you read that? I'm just wondering where that's going. Like you said, this is always changing all the time, and how do you see this developing into treating or finding out about breast cancer by blood tests?
So there's various tests that can be done in the blood to help, monitor those patients who might already have breast cancer. For instance, breast cancer tumor markers can be done in the blood. That typically is done for those who already have, say, stage 4 metastatic breast cancer. It allows us to assess treatment response, right? If the tumor markers are significantly high, right, we want to be able to follow the treatment and see how it's working. And if the numbers are going down, then that means, okay, it's likely working, right? But if it's continuing to go high, that means, all right, we might have to, re-image and just probably change treatment. There are other tests as well, something called ctDNA, circulating tumor DNA, that also can be used for those patients who have had at least stage 2 breast cancer. And basically, it's trying to detect in the blood, this is just one vial of blood that's sent out to special tests, looking to see if there's any kind of literally circulating tumor, so DNA that is shed off from these cancer cells. And if there's any evidence of that, then that tells us in terms of prognosis that there might be a higher risk of breast cancer happening, breast cancer recurrence. But it does not change management at this moment. So there's various, but there are various blood tests out there that are, that we are currently studying, and it's not necessarily standard of care at this moment to be included in treatment and things like that, but it's ongoing research, yeah.
Hi, thanks very much. It was very informative. If you have dense breasts, is it better to get a sonogram and a mammogram at the same time, or to space them out over 6 months so that you're checking every 6 months rather than just at one time?
That's a good question. And you could do it either way. The radiologists like you to do it at the same time because the two tests work well together. And so they can see if they see a mass on the mammogram, then you have the ultrasound with it. When people are at elevated risk, we do spread out the imaging. If they're going to get breast MRIs, we often spread it out by 6 months. So it's not a bad idea to spread out testing if you're at elevated risk, so you're getting 2 checks a year.
Thank you.
You mentioned a lot of what I suspect might be very specialized tests. Are any of the things that you mentioned not readily available or considered experimental, or they would all be available to anyone?
These tests I mentioned should be readily available. Like I said, there's ongoing research, right, looking at certain tests that might not be standard of care, but they should be readily available. Yeah.
Well, I want to thank you all for coming. I want to thank you all for listening and staying. I really want to thank our 2 speakers, Dr. Kapasi and Dr. Fong. I thought they did a great job. We're going to take a summer hiatus, and I think we're going to restart in the fall with prostate cancer. We're going to swing over to the male gender this time. I hope you'll enjoy the medical series. If you want to support it and support our library, on June 14th, there is a fundraiser with actually a band that I play in at the library, so I'm shamelessly promoting it. It's not a lot of money. It's going to be a great night. I hope you'll all come out. Otherwise, again, thank you for coming. It's really been a joy. Take care.